Welcome to the deep dive. Today we're tackling a topic that's really key for anyone prepping for exams like the MSRA.
hmm
But honestly, it's also just fascinating how everyday things can affect our sight. We're talking
Yeah.
about toxic optic neuropathy.
Exactly. Think of it as, a focused look at how certain drugs or toxins can actually harm the optic nerve.
Right, the nerve connecting the eye to the brain.
Yeah, leading to vision loss. We'll break down what you really need to know, hopefully in a way that sticks,
Yeah.
for diagnosis, management, all that.
Okay, sounds good. Let's dive right in then. So, in simple terms, what is toxic optic neuropathy?
Okay, simply put, it's when that optic nerve gets damaged or just doesn't work right because of
It's
exposure.
exposure to toxins or medications.
Precisely. And the main point here is it's a direct toxic effect on the nerve itself. It's not primarily about pressure or swelling. It's the substance doing the damage.
A direct hit. Got it.
So what kind of substances are we talking about here? What are the main culprits?
Yeah, this is crucial. And there's actually a pretty helpful mnemonic to remember the big categories. It's AABCBOT.
AABCPOT.
AEBCBOT. Okay, I'm intrigued. Let's unpack that.
Right. So the first A is for alcohols. We're mainly worried about methanol here, maybe found in like industrial stuff.
Or dodgy drinks sometimes.
Yes, exactly. And ethylene glycol, antifreeze. Their breakdown products are the problem.
Okay, A for alcohols. What's next?
Second A is antibiotics. Think chloramphenicol, maybe linezolid, some sulfonamides.
Okay.
Then the first B is antimalarials. Hydroxychloroquine is a big one people know. Chloroquine, too, often used long-term, which is relevant.
Right, the duration matters.
Definitely. C is for anti-tubercular drugs, isoniazid, and especially ethambutol. Ethambutol is known to mess with mitochondria in the nerve.
Okay, mitochondria, got it.
Yeah.
AEBC, does the next A?
Antiarrhythmics. Amiodarone is the classic example here. Sometimes you can even see deposits on the cornea with that one.
Okay.
Then another C, anti-cancer meds. Vincristine is one example.
P stands for PDE inhibitors. So think sildenafil.
Okay.
Each ed is heavy metals, lead, mercury, things like that. They can disrupt all sorts of cell functions.
Makes sense. We're almost there. Oh.
O is for others. Carbon monoxide is a good example here. Affects oxygen transport.
Right. And finally, T.
T is for tobacco, although its effect is often considered more indirect, or it works together with other factors like poor nutrition.
That mnemonic, AABCPHET, that's really useful for grouping them. It's quite a list, though. So thinking about exams, how does this fit into the bigger picture of optic nerve issues? What else might look like this?
That's a really important question, the differential diagnosis. See, toxic optic neuropathy causes optic atrophy nerve fiber degeneration.
Right.
But why did the nerve atrophy? That's the key. Was it poisoned, like in toxic neuropathy?
Or squeeze?
Exactly, like by a tumor. Or maybe its blood supply was cut off, ischemic neuropathy. Or maybe it's glaucoma, which is a totally different mechanism.
So different ways the nerve can be damaged.
Precisely. So you have to think about other primary optic nerve diseases. Glaucoma, optic neuritis, often linked to MS, trauma, compression. Also primary retinal diseases that can affect the nerve secondarily.
Okay.
And don't forget things like ischemic optic neuropathy, hereditary ones like Leber's, metabolic issues, infections, even radiation. So often toxic neuropathy is kind of a diagnosis of exclusion, especially when you have that clear history of exposure.
Right. The exposure history seems paramount.
Yeah.
So who's most at risk then? Where do we see this exposure happening?
Well, obviously the main risk factor is exposure to those substances we just listed using the mnemonic.
Yeah.
But to be more specific, think about, say, someone on long-term anti-TB meds, like ethambutol. Prolonged use ups the risk.
Okay.
Or occupational exposure, working with industrial chemicals, maybe without great safety measures.
Right. Unfortunately.
And then alcohol abuse is a big one, often linked to methanol, but also...
Nutrition comes into play too, doesn't it?
Absolutely. Poor nutrition, especially lacking B vitamins, seems to make the optic nerve, well, more vulnerable to these toxic hits. So, yeah, someone with chronic alcohol issues and a poor diet is definitely at higher risk.
So we know the what and the who. How about the how? How do these toxins actually damage the nerve cells, the pathophysiology?
It varies a bit depending on the specific toxin, but there are common pathways.
Okay.
One is just direct toxicity. The substance itself, or what it breaks down into, directly harms the nerve fibers.
Simple enough.
Another really key one is mitochondrial dysfunction. Remember the mitochondria? Powerhouses of the cell.
Yeah.
Many toxins mess with their energy production, can lead to cell death. Oxidative stress is often involved. Too many harmful free radicals.
Okay.
Some toxins disrupt normal cell metabolism. Others might even impair blood flow to the nerve, causing ischemia. So multiple potential hits.
Right. It's like attacking the nerve from different angles.
Yeah.
So when a patient comes in with vision problems, what are the classic signs and symptoms that scream, think toxic optic neuropathy?
Okay, the presentation is often quite typical. Usually it's bilateral and pretty symmetric vision loss.
Both eyes, fairly equally.
Yeah, generally. Patients complain of blurriness, vision not being as sharp, maybe colors looking washed out or different. And you absolutely must ask about drug history prescribed, over-the-counter, recreational, plus alcohol, and any potential chemical exposures.
That history again.
Always. The vision loss itself is usually painless and comes on gradually. A classic description is a blur right in the center of their vision, what we call fixation blur.
Okay, that central blur. What about when you examine them? What do you find?
Well, you'll usually find reduced visual acuity in both eyes. And a really key finding is dyschromatopsia problems with color vision, especially reds and greens often.
Red-green specifically.
Often, yeah. And visual field testing is crucial. It typically shows a central scotoma, that blind spot in the middle, or a secocentral scotoma, which includes the center and the blind spot area.
But the edges are okay.
Usually the peripheral vision is relatively spared, which is quite characteristic. It points towards damage to the papillomacular. Bundle the fibers for central and color vision.
Okay.
Later on, if you look at the back of the eye, you might see the optic disc looking pale. That's optic atrophy setting in. And another subtle clue. If it's symmetric, you often don't see a relative afferent pupillary defect, or RAPD.
Right, because both eyes are affected similarly. That pattern, the central defect, really helps picture it. So if you suspect it based on all this, what tests do you order to confirm or rule out other stuff?
Right, investigations.
Yeah.
So after that detailed history and the eye exam acuity, color, fields, looking at the fundus, we move to specific tests. OCT, optical coherence tomography, is super useful. It can measure the thickness of the nerve fiber layer and show thinning, especially in that papillomacular bundle region.
Okay, OCT is key.
Definitely. Then blood and urine tests. You do toxicological screening if possible, trying to pinpoint the agent, and you'd almost always check vitamin B12 and folate levels, given the nutritional link.
Makes sense. Anything else? Imaging.
Yeah, depending on the situation, you might get an MRI of the optic nerves and the chiasm, usually with contrast. That's mainly to rule out other things like tumors compressing the nerve, or inflammation, or MS-type lesions.
So ruling out the mimics.
Exactly. Visual evoked potentials, VEPs, can sometimes help. They measure how fast signals travel along the optic nerve. In toxic neuropathy, they're often slowed down.
Okay.
And, if you suspect something specific like amiodarone, you'd look closely at the cornea with a slit lamp for those deposits we mentioned. Sometimes, if things are still unclear, you might need genetic tests for hereditary conditions or further neurological checks.
Okay, comprehensive workup. So let's say we've confirmed it or we're highly suspicious. What's the management plan? What do we actually do?
Right, management. The absolute number one, most critical step. Identify the offending agent and stop the exposure immediately.
Stop the drug, remove the toxin.
Yes, that's the cornerstone. If you catch it early enough, sometimes just doing that can lead to some vision improvement, or at least stop it getting worse.
Okay, stop the cause. What else?
Supportive measures are important too. Good nutrition is key. Maybe B vitamin supplements if deficient. Antioxidants are sometimes considered, but the evidence isn't super strong there yet.
Right.
And then for specific toxins, there might be specific treatments. Like for ethambutol toxicity, we often give pyridoxine, which is vitamin B6.
Okay.
For methanol or ethylene glycol poisoning, you need to correct the acidosis, give specific antidotes like fompazole.
Right.
The
Okay.
antidotes, maybe even steroids. For heavy metals like lead, you'd use chelation therapy to pull the metal out of the body.
So tailored approaches for some, but the main thing is removing the cause.
Absolutely. That's the primary treatment.
Right.
And then, of course, you need to monitor them closely.
How often?
Regular follow-ups are vital. Checking vision, pupils, the look of the optic nerve, color vision, visual fields. Initially, maybe every 4 to 6 weeks, then perhaps stretching out to every 6 to 12 months, depending on how things are going.
Okay. And what's the outlook? Can people get their vision back? What's the prognosis?
The prognosis.
Yeah.
It really varies. It depends heavily on how bad the damage was, how long the exposure lasted, which toxin it was, and crucially, how quickly it was stopped.
So early intervention is key.
Very much so.
Yeah.
Unfortunately, some vision loss can be permanent. The optic nerve tissue, unlike nerves elsewhere in the body, doesn't really regenerate well.
Right.
So once you have significant optic atrophy, that pallor of the nerve, that's generally irreversible damage.
So the goal is stopping it getting worse.
Primarily, yes.
Yeah.
Stop the progression and hope for some partial recovery if possible. But full recovery isn't always realistic, unfortunately.
Understood. And what are the main complications we worry about?
Well, the biggest complication is simply the persistent vision loss itself. It can range from mild blurriness to severe impairment, impacting quality of life, driving, reading, work, everything.
Yeah, significant functional impact.
Exactly. The extent depends on how much nerve damage occurred.
Okay. Wow, this has been incredibly thorough. A really good deep dive into toxic optic neuropathy. It's just someone revising needs. So could you just summarize the absolute key takeaways for us?
Sure. Okay, key points. Toxic optic neuropathy is optic nerve damage from toxins or meds. Remember AABCPHET for the causes alcohols, antibiotics, antimalarials, antituberculars, antiarrhythmics, anti-cancer, BDE inhibitors, heavy metals, others, tobacco.
Got it.
Clinically, look for that bilateral, symmetric, painless vision loss, often with poor color vision and a central or secocentral scotoma. History is vital.
History everywhere.
Yes. And management. Number one, stop the exposure. That's the most critical intervention.
Fantastic summary. Really clear. And if you, our listeners, are looking for more top-notch revision resources like this for the MSRA, definitely check out passthumbsra.com.
And also freemsra.com for loads of free questions and guides.
Great stuff. Well, thank you for joining us on this deep dive into a really important condition. Makes you think about how vulnerable our vision can be.